Okay, thank you very much. My name's David Davis. I'm the chairman of the Red Lion Group, and it's my delight to welcome Red Lion Group members, friends and families, and also hopefully some people from the Kangaroo Club, sister charity over in Oxford, and also some subscribers from the J-Pouch UK specific Facebook group, and anyone else who knows us. It's a delight, really a delight to welcome you to this, the latest Zoom webinar on behalf of the Red Lion Group. My thanks to Gary for pressing all the buttons and for general tech brilliance, and also to my colleague Christopher Brown, who's lined up our speaker today. It'll be my very great pleasure to introduce in a moment. Just to mention that we have the last in the series of webinars coming up next week, same time next week on Thursday, with Professor John Nichols, a luminary in pouch surgery, the ex-consultant colorectal surgeon from St Mark's Hospital, who will be giving his own personal reflections on the development of the pouch operation way back when, 40 years, when we were a glint in some people's eyes. So really pleased to hear John's thoughts next week. It'd be great to have you join that one. We went through the admin, so I won't repeat that. We need to crack on. But I'm absolutely delighted to welcome our speaker today. Zarah Perry-Woodford is her Facebook profile says lead nurse, pouch and stoma care at St Mark's Hospital.
I have a Facebook profile.
That's a little bit out. Sorry, not Facebook, the St Mark's.
I was gonna say.
But her role has grown and expanded in recent years, and she now is the NHS Collaborative Procurement Project participant. That's called the Ostomate Project, which is a national procurement project for stoma products. So I'm sure she'll be able to tell us a little bit more about that. It sounds fascinating. Zarah, I'm going to read this because it goes on a bit, has been a pouch expert for some time. My apologies for reading it. She's a qualified nurse, and her first professional roles were with the RAF, working on colorectal wards and stoma wards. And then she moved to St Mark's and joined the stoma care department in 2003. She worked there and began expanding the pouch service in 2005, providing expert care to patients with ilioanal pouches, both pre and post operation. In 2018, she became a consultant nurse for pouch and stoma care, and she remains involved with current pouch stoma research, guidelines and protocol development, and professional education initiatives. So she's a real star, and absolutely fabulous to have you join us today. She also, and I meant to get my copy here, where is it? Goodness me, I'll have it for the end. She also authored a book, The Ilioanal Pouch Surgery for Ulcerative Colitis, a guide for patients, which is available for a mere £10, the same as Red membership for PCO.
Gary's got it.
And available from Waterspoons and other good booksellers. So thank you very much indeed, Zarah. It's great that you've given your time and energies today, and I'm sure the audience will be, like me, delighted to hear your thoughts and expert advice and reflections on pouch care. Over to you.
Thank you very much, David, and thank you very much to the Red Lion Committee for inviting me. Chris kind of gave me free rein of a topic, so I kind of done a bit of a mismatch. I'm going to go through the history of the pouch service to start with, and then go through my secondment at NHS Supply Chain. So let's see if I can do my IT.
Press screen and then open your PowerPoint and say share. It's coming up. There you go. And now go to slideshow. Brilliant.
Ooh, well, we might be getting there.
Okay.
Outstanding.
There we go.
Right. So, the aim of this session then is to look at the history of the pouch nursing service. I know I have a different audience. There might be some people out there who've had a pouch for a long time and probably more expert in pouches than I ever will be. And then there might be people who have or are thinking about a pouch or have a relative with a pouch. So it's just going to give you a little history of the pouch nursing service. Chris said if I had any new developments, any secrets, so I might drop a few of those as I go along. He also asked if I could explain my nurse consultant role a bit and the work that I'm doing on my secondment with NHS supply chain. And then you can't do a presentation these days without talking about COVID-19, but it really has changed the face of nursing. And having been a nurse myself for about 20 odd years, this has really brought some difficult times to nursing, but it's also really brought out some positive things. And it's really sort of moved technology forward. It's a shame I couldn't keep up with technology this morning, but it's really going to change the way that we nurse in the future and the service that you receive. And then we're going to have about 15 minutes, hopefully, for questions. So first, I'm going to start with a little story. Once upon a time, in a small operating theatre, two surgeons had a dream, Professor Nichols and Sir Alan Parkes. A dream to allow select patients the opportunity to live without a permanent stoma and evacuate the way one was intended. However, there was a non-technical flaw developing, one that would not be recognised for some time. So they had a brilliant hospital, St Mark's Hospital in Harrow, that's where we are now. We had a brilliant surgeon, Professor John Nichols, but it took 20 years to realise that they were missing a pouch nurse. And that happened in 1996, when the first pouch nurse by the name of Julia Williams came and supported the surgical team and sort of opened a diverse, different way of supporting patients. Some of you may remember Julia. After Julia, Joe Wagland took over the service, and then I did in 2005. And this was a single nurse-led service. And I realized very early on that with 70 or 80 new pouch patients a year at St Mark's, it being a centre of excellence, that we couldn't do this alone. We also ran a nurse-led clinic, and that needed more support as we were getting more and more patients in. So the team grew, and many of you know Lisa, who in 2010 joined the team. Lisa is currently on Frederick Salmon Ward helping out with the COVID-19 patients there. So she's been redeployed. She should be back by the end of the month, this month, yes. And then Samantha, who was with us for 5 years, who's left and gone off to work in the world of enhanced recovery, but she is still at St Mark's. The nice thing about the pouch nurse service is that there's more than one of us now. But the little secret I shall drop in is Joanne, myself, Lisa and Sam have a twin sibling. So it seems to be part of the job description of a pouch nurse. You have to have a twin. Back in 2005, the Stoma team structure was very different. As you can see, we had one pouch nurse, that was sort of me at the time. We had two stoma nurses that also managed all our patients with intestinal failure, which is now intestinal rehabilitation. And we also had one stoma nurse that covered the community patients in Harrow. And that was managed by a lead nurse. And having now lived in the world of management, management takes up a huge amount of NHS time and really does take you away from nursing. So the service for the pouch patients was sort of quite small. When I was asked to manage the entire stoma service, it was a big commitment for me because I'd been the pouch nurse for 10 years by then. And I kind of got into my little routine. I knew my patients really well, and I'd almost forgotten stoma care. And I really didn't want to embrace management per se, but I'm really glad I've done it because I think the only way you can change a process is by being completely involved in it. So the one thing that I wanted was a vision for our stoma care department, and that vision still stands today. And that's to make sure that every patient undergoing stoma forming surgery is well supported, understood and empowered to ensure optimal quality of life is restored. And that sort of works whether you've got a pouch or if you have a stoma. but it's very difficult when you don't have the manpower or the workforce. So I've kind of spent the next 4 years actually, working on a better structure. And that's what our Stoma team looks like now. So I sort of manage the team, but from a very far distance, because I now have my lead nurse, Joy, who has been amazing in enabling me to do more management sort of structure changes and work at a more corporate level. We have very good contacts with the head of nursing, and I have a very supportive manager. And we also have Mr. Waris Sabatani, who did a talk last week or the week before, and he has been instrumental in supporting the Stoma team for many, many years. The pouch team now, as you can see, we've got, we've got Lisa, with Lisa being away, we still have two nurses that manage the pouch team. I've come back to do a little bit more with Petia, and Chris, who works 2 days a week with us. The Stoma care team, as you've noticed, has also grown. I now have 13 nurses. 2 are on long-term leave for a while, but we definitely have a stronger team. We also have a community team of nurses, Debbie and Kendall, who work across Brent, Harrow and Ealing CCG. So in 2016, when the trust merged, we also have patients in those communities as well. It's slightly different as well that we have a more interaction between the Stoma care and the pouch care department. One of the problems of having very specialized nurses is if somebody leaves or moves on, there's a huge void. So we're trying to interact more with the Stoma nurses and vice versa, so we can support our patients better and really learn from each other. While we're here, we'll put some faces to names. So that's Petia on the left and Chris. So another little secret I'll drop in to keep with the theme and the job description. Petia also has a twin. And the other exciting thing, so you don't get confused, Raleigh, who's her sister, is also a Stoma nurse in the department. So that was a good deal. So who are we as the pouch nurses? Well, we are all qualified Stoma nurses. We've got varying degrees, but a huge amount of experience in Stoma care nursing. But those of us who have a specialist interest have advanced training and skills in ilioanal pouch care. A lot of it is learned on the job. There's not a certain module or university degree on pouch care, but we do run one of the UK pouch masterclasses for nurses or people who want extra training. So we are quite a unique nursing team. What we do, now sorry, I'm just going to fiddle with this because my pictures are all over my slides, sorry. We offer long-term physical and psychosocial support for any patient thinking of a pouch, living with a pouch, or those who've had a pouch. We advocate between the gastroenterologists and the surgeons for our patients. So maybe if you're thinking about having a pouch, but you're not quite ready to speak to a surgeon, your gastroenterologist might ask us to speak to you, and we're more than happy to do so. We offer pre-op, post-op, and lifelong support to patients. We run nurse-led face-to-face outpatient clinics, telephone and email advice lines, and hopefully virtual clinics very soon. We contribute to pouch research and publication, and also nursing and medical education as well. We link to national support groups, such as yourself, the Red Lion Group, and I've just realized that my t-shirt's a little bit out of date now because you've changed the logo, and also the Ileostomy Association and Internal Pouch Support Group. Some facts and figures. So St Mark's Hospital is the main tertiary referral centre in the UK for ilioanal pouch surgery. We currently have 4 colorectal surgeons that fashion pouches, and they are either done laparoscopically or with open procedures. We were one of the first hospitals to do pioneering work into SILS, which is single incision laparoscopic surgery, where most of the work is done through the stoma site, so patients don't have multiple incisions on their abdomen. We have the research facilities and research teams. We also hold a national database, and we are trying harder to keep a stoma and pouch database, modernize things, but we do have also the dedicated pouch nurses, and that's the only centre in the UK with a team of pouch nurses. Now, I'm not going to go through too much of the anatomy because Janindra did this a couple of weeks ago, but we do see patients from the time that they have decided to have a pouch operation. The J pouch is still the most common configuration of pouches that we do, and people usually have a two-stage operation, usually the patients with FAP, familial adenomatous polyposis, or the patients with ulcerative colitis, who usually have a subtotal colectomy first, get better, get off their medication, have a think about things, and then come back and have their pouch formed. Usually this involves the pouch being created and a loop ileostomy being formed, and then the patient coming back in about 3 to 4 months and having the ileostomy closed. What we have done, and Mr. Warasavatani has pioneered, is the modified two-stage restorative proctocolectomy, where patients with ulcerative colitis come in and have their subtotal colectomy, get rid of their colon, bit of the rectum stays intact, and instead of having the pouch formed with a covering ileostomy, what Mr. Warasavatani can now usually do for select patients is create the pouch without a loop ileostomy. This saves the patient having to come back for another operation. And for the pouch nurses, we do have to invest a little bit more time in these patients because we have to go a little bit slower, because obviously we haven't had the covering stoma to protect the pouch. But we don't work alone at St. Mark's. St. Mark's is a special place in that we're sort of under an umbrella of support. The pouch team work closely with the IBD nurses, the Macmillan nurses, the outpatient team. And as you can see from there, it's quite an extensive list. So if we usually don't know the answer, there's usually somebody who can. Now, people always ask this question: what's happening with pouches? Are we getting less pouches? Why is that happening? Now, this is one of my old slides that I had. And as you can see, back in about 2006-07, the average number of new pouches we were doing at St. Mark's was about 45. We did have a spike in about 2010, was it? Where we had 60, but we were averaging about 40 new pouches. We also defunctioned or excised pouches that had failed. So those were people who either decided that their pouch had run its course or they were having quite a lot of complications and chose to revert to a stoma. So on total, we had probably over that period, the average was about 20 pouches that had either been defunctioned or excised per year. If we look at our current figures, and I have to thank Petia for dragging these out and helping me do them, but if we notice, oops, sorry, now the average pouch has sort of dropped. We're doing probably about 23 new pouches per year, of which the number of pouches that we defunction and excise at St. Mark's has greatly increased to about 35 per year. But we've got to take these statistics in comparison to what's happening in the world, that there are some reasons that we're doing less in the fact that other institutions do pouch surgery now. There's changes with the drugs that we use, the biologics. And patients are probably thinking a little bit more about their quality of life and having time to do research and decide if they want a pouch or not. But as you can see, last year in 2019, we've had another spike. So our numbers seem to be going up for new pouches. And this may have something to do with the techniques that we're using or other factors which we can discuss. We can also see that there is a trend that we aren't redoing many pouches. In fact, over the last 3 odd years, we haven't redone any pouches at St. Mark's. So that just gives you a little idea of what the workload is. Saying that, though we have reduced the number of new pouch operations we have seen a spike in a lot of patients needing extra care and support because their pouches are getting older. We're now into about the 42nd year of pouch surgery, so we've got some quite established pouches out there. Anybody really can be referred to the pouch service. We usually get a lot of our referrals from tertiary consultants, so consultants from other hospitals, or patients can refer themselves. If you've got a pouch question, we might have to get a referral from your GP for a medical history, but most of the time we can start to help. We've got a direct phone number, and we have got one email. Even though we all have our individual emails, what we realized a couple of years ago was that we now have a joint email, which is that email there, and all the pouch nurses, in fact, the entire Stoma team can access that email so that a patient can get support. Talking about support, when we have seen our patients in clinic, when you're new and thinking about a pouch, it is overwhelming because we're talking about stoma care as well as an internal pouch. And for a lot of patients, it was quite overwhelming to think of pouch surgery. So after doing my master's on my thesis on pouch failure, it kind of hit me as a nurse that a lot of patients didn't really think that their pouch was going to fail. And indeed, they probably didn't understand enough about the pouch. So I decided on the back of that, with help from Lisa, Janindra, and lots of other people, and patients who were kind enough to give an honest opinion about their life with a pouch, I published this book in 2016. And I have to say, it has been phenomenal how well received it's been, and also how many people have said it's benefited them. And I'm really pleased because that was the intention. So it goes through everything from stoma care. And I see Gary's kindly put a little plug on the website for me, but this book sort of went itself. And we even had to reprint it in 2018 because I think so many copies had disappeared and they went all around the world. So that was really good. Little secret to drop in there then is because we want to do the same thing for our pouch patients. So Petia and Raleigh have written a patient guide for stoma patients. So we're trying to edit that and get that out in print as well. So that's something not relevant to all pouch patients, obviously, but something that the stoma care pouch team are doing. We also have a lot more online information or electronic information. So we're trying to keep our website up to date, the St. Mark's Stoma Care website. And these are the sorts of things that a lot of people use with a pouch, a dilator or a Medina catheter. And it's just having the information available, not just stuck in a book somewhere or needing to contact us. So these are the sorts of little leaflets that we're trying to do, put together and get electronically. As pouch nurses, we also collaborate with the surgical experts. I should say Mr. Warasavatani himself and I have written a book last year. It's a medical book, mainly for, I would say, the medical people to understand pouches and general management and troubleshooting. However, it was very interesting working that closely with a surgeon. And it was a real benefit to learn myself from masters of pouch surgery across the world. So again, a very good resource. And I also have to say, we publish in nursing and medical journals. Those are just a few journals and articles I've written, but I do have to say the ones that have been highlighted, I do have to thank my pouch patients, because again, Scott, Julia and Kenny from the Ileostomy Association were brilliant in helping me write a paper on the lived experience, which was then put into Janindra's and my book. So it really does help to get that lived experience, and also all the patients that helped me do the quality of life article back in 2013. So we're always asking for a little bit of help from you. This is something which I've wanted to do for some time, and Petya has been instrumental in pushing me and guiding us. But this is, I know you can't read it, but a protocol we've just written, and it's been reviewed by Professor Clark, just so that people know what sort of conditions the pouch nurses will see. So in that box which I'm highlighting, and then the clinics. So we do have a telephone clinic and all the sorts of complications we can deal with. Then we have our booked clinics, our complex clinics run by the more experienced pouch nurses, where we can do rigid scopes and request different tests and actually prescribe. And then we have our rapid access clinic, though it's not a drop-in clinic, but it's a clinic that we can book you into rather quickly, that we can see patients. And then we have our joint clinics, where the pouch nurses sit with the surgeons and the gastroenterologists for more complex pouch problems. And then we have the surgical clinics and the medical clinics, which if we can't manage any of our complications, we can refer into these clinics and get our patients seen as quickly as possible. The other thing that we do at St Mark's, and again, we've had a lot of support from our surgical and medical colleagues, and this is looking at the protocol for the treatment of cophitis. So pouch patients also end up with conditions that GPs and most people don't understand. So this is inflammation of the tiny rectal remnant that is left at the base of the pouch, which sometimes does get inflamed. So this is just a protocol which we're going to sort of try and share nationally. So even if you aren't under St Mark's, if you do think you've got cophitis, that your GPs can refer to documents like this and actually give you the appropriate treatment. How am I doing for time? Okay, not too bad.
Yeah, you're fine, Zarah.
Okay, so I'm just going to go through the national work and why I got involved. So this is the reason I got involved. Now, that is a couple of rubbish bags with excess stoma boxes. And then there's a box with accessories, seals and sprays. And these are things we usually get delivered outside our door. That was a good selection. Or we get little notes left on rubbish bags that say, please, can you send these off? Now, wastage is a huge problem for the NHS, especially when you think a box of stoma bags cost approximately £100 odd for the GP. And London Procurement had sent questionnaires about sponsorship, how nurses work, how we see our patients, where the wastage could be. And to cut a very long story short, I kind of ignored this questionnaire for some time because I wasn't quite sure who London Procurement was and why they were asking nurses these sorts of questions. However, I did get sort of called up by my manager at the time and was asked to fill in the questionnaire. But I said I'd rather like to speak to somebody to find out what London Procurement and procurement was doing, because my concerns were that they were going to sort of look at the types of stoma bags on the market, look at the cost and probably reduce the cost and therefore the quality of stoma products without having nurses and, more importantly, patients involved. So I suggested a meeting with the team at London Procurement and they came to St Mark's, and at the end of it, they actually offered me a job. So I said, no, thank you. But I was willing to do a secondment with them to be involved with national work. And back in 2017, these were the figures in London. There was a £25 million annual spend in the community. So that's the prescribing budgets that GPs have in London, of which nearly £2 million was on adhesive removers. Now, my concern was that they were just suddenly going to cut products, and that has happened. And we've seen in Scotland where nurses and sponsorships and decisions are made. And I thought, well, I'm not going to just be able to do this sitting on the sidelines. I do have to get involved. So in 2017, I did leave the stoma care management job as my consultant nurse post and joined the London Procurement Collaborative Hub. And their mission or aim was to understand the increasing stoma spend in London, but achieve a transparent and sustainable stoma care service for the future, because the NHS is not an endless pot of money, and we all do have to make sure wastage is managed, but also that the NHS does still provide high quality care and value for money, but being sensitive to the needs of all stakeholders. And after doing this project for about a year, we came up with some very good documents. Our first document was looking at actually the number of stoma care patients in London, trying to get a register of stoma patients, of nurses, and also looking at the way that industry works, the way that DACs, so those are the dispensing appliance contractors, work, making sure that this was a bit more transparent, that patients didn't have to have problems getting prescriptions or prescriptions being signed, looking into different ways of making the systems more effective without reducing care or compromising it with cost. Having done that for a year, NHS supply chain got involved because they thought, well, NHS supply chain, sorry for those of you who don't know, is a national procurement hub, and they are the people that are responsible for all of the buying and procuring products into the NHS. So they will source the products, they will get the deals, and products from wipes to needles to theatre equipment all come through NHS supply chain. I still fully don't understand how all the towers work, but in a nutshell, NHS supply chain asked if they could have my services on the Stoma project. It was a project which then took the work from London procurement onto a national level. Because I think though London procurement was excellent, we kind of hit a wall with being able to implement any of the ideas we had. Whereas with NHS supply chain, hopefully the idea of the project is working with other projects, such as National Bowel and Bladder Health, QUIP projects, identifying best practice, not just in London, but nationally. We want to engage with the stoma specialist workforce. So it's not just me being the stoma nurse opinion, wanting to make sure that stoma nurses can agree pathways, make sure patients have a voice along the pathway, make sure that we can identify some models to support timely, efficient and equitable product access. So patients in Cornwall have the same ability to get products as we do in London or anywhere else in the country. And then to develop some sort of patient-centric toolkit. And I've got to learn a whole new vocabulary here. But this toolkit to make sure that nationally we have guidelines and protocols for best clinical management. And the great thing about me still being clinical is I can try these ideas out without doing a big document and then realizing this would probably never work. So I get a lot of feedback from my patients, I get a lot of feedback from my team and my colleagues to support the work. And talking about support, we couldn't do this without our patients. And I think my pouch patients have always been the driving force. And I think it's really important. And this just goes to show that when I kind of realized I had no funds to publish my pouch book, one of my pouch patients, Annan, came up to me, said, "No problem, Zarah, I'll fundraise for you." And I was just like, I need quite a lot of money. But amazingly, he managed to fundraise and gave £2,000. And then Mr. Warasabatani contributed the other 1,300 towards the publishing cost of the second edition of the book. So it's just absolutely amazing how our patients still support us. But it's not always happy going, I know, for our pouch patients. I know there's sometimes problems getting through to us, our staffing, our phone lines. And it's a difficult time for nursing. And I always like to draw on the positives, even in bad situations. And I'd like to remember one of my very influential patients. And this was Joe. Joe I met in 2015 when he came to us for a pouch. He had his pouch done, but he had ongoing rectal cancer, which we did his pouch for, but then unfortunately developed metastatic disease, which we had to defunction his pouch. Joe actually died in October 2017, and it was devastating for me, the nursing staff on the ward, the entire pouch team, because Joe was one of those patients that as ill as he felt or as sad as he was about his pouch or what was happening, he always worried about the other patients in the bay, and he always worried about the nurses, and he worried about us working too hard. And I have to say, Joe has given me my drive to keep changing the way the pouch service should support patients. And when I felt really low, I always remember Joe saying, "Don't dwell on the fact that you can't save me or my pouch. It's the way you've saved me already that counts." And it sort of reminds me that when it does get tough, that we have to keep going to make the lives of pouch patients better. And that's happened with the pandemic. And I don't think nurses have ever seen something like this. I mean, this is close to some of the military nursing I've experienced in the past, where you just jump out of a plane somewhere and hope for the best. But this has really brought our team together. It's shown the strength of nurses, of doctors, of the frontline workers, of everybody who's been involved, and the patients who've actually really understood why we can't be at the end of the phone, and they've really tried to support us. But it's made us realize that we can't continue the way we are going or have been going. And thankfully, we have found funding for better technology. So what I'm trying to look at with the pouch team is actually streamlining the nurse-led telephone and email support. We've now got an iPhone, and as you can imagine, I can't use the thing yet. So we're going to look at seeing if we can send texts to patients. So many of my pouch patients are young. I give them a card and they're like, "I'll just take a picture of that and put it in my phone." I'm like, "So you don't want my card then?" They're like, "No, Zarah." So I know things have moved on. Appointments, reminders coming text. We're going to try virtual clinics. I do have a laptop now with a camera, and hopefully we'll get that set up and try some virtual clinics. I might get some of my pouch patient volunteers to ring in and see if we can help virtually. We've spent a lot of time designing new patient protocols and guidelines, and a website, and analysing our Stoma quality of life data. So these are all the things that hopefully we can do, and redesign the entire patient pathway so that patients are more supported. And the only way we can, and webinar, sorry, the only way we can do this is by capturing your feedback. So we would really appreciate if you could email us or tell us what you do want from a pouch nursing service, because we know that the only way that we can make your journey better and enable us to give better care is to make time now so that we can provide individualized care and better manage pouch problems in the future. Because our role is to improve patient experience and quality of life. And I think that's me done.
Excellent, Zarah.
That is absolutely outstanding. Thank you so much, Zarah. I have to say, Zarah, I spoke to you this morning. She was nervous about this. That was absolutely outstanding. It's very difficult to do this without an audience sort of laughing and sort of shouting and screaming. It's just talking to a computer. So I thought you did a really great job. Now, everyone, just a quick tip. On Zoom, apparently, when you do a round of applause, you just put your hands up like that and do that. So we can all do that for Zarah. Thank you very much. You're all muted, you see, so you can't hear the clapping. So well done. Thank you indeed for that. Just before we get into the questions, we have a whole raft of questions for you. So there's lots going on, but just two things I wanted to mention before we start the questions. So just bear with me. The first is, as Zarah mentioned, you know, one of Zarah's colleagues is Lisa Allison, and we're absolutely delighted on the Red Lion Group Committee to have Lisa as one of our key members, and also a past chairman as well. So she's really done her stint in terms of the Red Lion Group Committee. So I forgot to mention that at the start, but big hands to Lisa. The second one.
Can we clap?
Big clap for Lisa, yeah. Thank you. The second was you raised some fundraising initiatives, and I'm going to spare his blushes, not at all, but Anand Jatania is actually on the call. So Anand, absolutely delighted to see
more clapping.
£2,000, absolutely wonderful. And if anyone else fancies raising money for Red Lion Group or indeed for the Red Lion Foundation, obviously we're delighted to help you along there.
I've got a hand.
We've got some big questions here, so lots and lots of questions. So thank you indeed very much for submitting your questions, and please continue to do so. They don't really fall into general categories, so I'm going to kind of ad-lib this a bit, but we'll try and get through as many as we can. So the first thing is tertiary referral, because it refers to a number of the comments here. Tertiary referral, can you just explain the nature of tertiary referral and the types of patients that you might get referred because you're a tertiary referral centre? I'm thinking about complexity and problems.
So what I would say is tertiary referrals are any patient who lives outside the boroughs of Harrow, Brent and Ealing. So those are our local catchment areas for St. Mark's Hospital. So anybody who's not in those areas have to come through as a referral from a GP or a referring centre, so a consultant, surgeon, gastroenterologist at another centre. Because there is not another centre, ideally like St. Mark's, for pouch patients, anybody who needs a second opinion, anybody who'd like to have their pouch done at St. Mark's, anybody who would like to discuss their complications or anything, you can come to St. Mark's. So as long as you have a pouch, we should be able to get you into St. Mark's Hospital. And the idea is that you may have surgeons that do pouches in other areas, but as St. Mark's Hospital is a centre of excellence, it's not just the nurses. And you saw from my umbrella, pouch patients don't just need a surgeon and a nurse. You do need an entire team. You also need the right investigations done at the right time, and you need them to be reviewed by the correct people. So there's lots of times that people may have had an MRI scan or a pouchoscopy at another hospital, and unfortunately, when the report's been read, it's been read incorrectly. So it's sometimes easier for patients to come to us because we have a slightly better idea of the complex pouches.
Okay, that's great, thank you. So if you're not a patient of St. Mark's, you can still be referred to St. Mark's.
Definitely.
If you're having problems, yeah.
Yeah.
Okay.
You will need a GP, as I said. We can give advice over the phone, but we do need medical history, and there is a funding stream from the GP. So we do usually need a GP referral
Yeah.
if you want to see the surgical or medical teams or be under St. Mark's as a patient.
Okay, so just to be clear again, I had a commentary from a lady who was being treated, not on this call, by the way, being treated from Queen's Medical Centre, I guess that's Nottingham, and she was having some questions and concerns about her care at a secondary specialist centre, and she eventually got referred to St. Mark's. So that was a separate secondary centre care centre because of your specific expertise with problems with the pouch, and that's available to any community.
Yeah.
Okay,
so even if you have a liver concern or PSC involved with your colitis in your pouch, you may be under another hospital for that.
Yeah.
For your pouch, you can be at St. Mark's.
Okay, that's great. Thank you. So coming down to pouchy problems. So some comments from people who are having problems with pouches, and we'll go through those in a minute because there's some general tips I think that you'd be able to help with. But also some commentary about pouches working and the concern about pouches becoming old or defunctioning. So how do you, first of all, tips for keeping the pouch in good condition? And secondly, what's the prospects long-term for pouches when they become old? And is there a risk there for people who've had their pouches for a long time? What's the future?
So I'm going to answer your questions the other way around. So the first thing is pouches do get older and their function unfortunately gets worse. So the statistic we tend to use is about 10% of pouches fail at 10 years. Now, failure means that the pouch is defunctioned with an ileostomy. So people go back to having an ileostomy, and that means your pouch has failed. So about 10% of pouches in 10 years. So though a lot of people may have pouches that aren't working as well, and as a medical person, we may have suggested you may want to think of a stoma. Some people have a pouch that they manage that probably we would have said has failed, but pouch patients prefer to keep their pouch because they know their other alternative is a stoma. So pouch, I usually say to my patients, having an older pouch is like being older. My knees aren't as good as I've got older. We wear glasses. You know, we have to do things to our pouch to help keep that pouch going. And that leads me on to our tips. The best tip I would say is have your pouch done at a specialist high volume center. High volume meaning a surgeon who does quite a few pouches per year. As you can see, even at St. Mark's, we aren't doing a huge amount of new pouches, but we do have the expertise. If you have your pouch done correctly in the first instance, you are more likely to have a longer, good pouch function. Once the pouch is created correctly, then again, I also think there's nothing that you can particularly do to make it last longer or do anything to make it last any less. However, having a healthy lifestyle, eating well, exercising well, there's lots of research into pouchitis, which occurs in about 50% of people with a pouch. And pouchitis can be triggered by stress. I did see something that came up about stress. And the gut is affected by stress. So just because you have a pouch does not mean that you're immune to stress and hormonal changes. People that eat regularly, that have a regular eating pattern, seem to evacuate the pouch more regularly. And I would say generally, if you have a problem with your pouch or you are concerned, is that you seek help. So a lot of people think, I'm not going to bother, you know, the pouch nurses because Zara and Lisa, or we're very busy. And what happens is that you probably try to fix it yourself and end up not making things worse, but reducing your quality of life and getting frustrated about things. So I would say those are probably, there's not tips to say this is how you can make your pouch better, but you can make your quality of life better if you have a bit of routine, diet, and a healthy lifestyle. I also have to say, people who tend to distract themselves a bit, so they work, they keep a routine, and they manage slightly better with their pouch.
Okay, Graham, that's really good, thank you. Just a quick follow-up on the earlier question. Can people from Scotland be referred to St Mark's?
That is a good question, and this is where I should have my team around me, which I am missing. I honestly do not know, because I want to say yes, but I am not sure, because we had this problem with funding stream from Wales. So I was seeing patients from Wales, and unfortunately the GPs had decided they could manage pouch patients in Wales. So that is a question to myself to find out the answer. Okay,
and if maybe we could share that back through Redline Group, we'll post 1 or 2 clarifications if necessary for the benefit of people.
But even if people wanted advice, we would be more than happy wherever you are, because we are an international centre as well. So we do have people that, you know.
Yeah. Okay, great. Just coming back on the stress front, I think that's excellent, and everything seems to come down these days to a healthy lifestyle, which is really disappointing for me because I don't have one generally. But I kind of get the message. But one thing about stress, we had a great talk last week from Yoram Inspector, who's a consultant psychiatrist, and he was talking about the way in which people with ulcerative colitis and other inflammatory bowel disease, it's not necessarily the stress, it's the way they process the stress. And the way in which you process the stress psychologically can have impacts on how much effect the stress has on you. So people who ask that question, I really would recommend you go back and have a look at the Zoom event that we had last week with Yoram Inspector, which has been posted, the recording's posted on the website. Have a look at that, have a watch of that. It's really a great presentation, and he does go into detail about things like the effect of stress psychologically, and about tips to process stress effectively if that's an issue. So that's a good follow-on from that.
I've just seen that one of my colleagues, Raleigh, has put her hand up. I don't know how she managed, that's just come up, and I bet she's got the answer for Scotland.
Okay, Raleigh, can we unmute you?
I just saw it flash up, but if it comes back again, I'll let you know.
Okay, Raleigh, you could either unmute yourself, if you can do that. Is she able to unmute herself and just speak, or indeed just type an answer onto the chat room, and we'll pick it up. So we'll wait and see what happens there. Oh, there you go, Raleigh. So you're unmuted. Do you want to say something?
That's good. I've just seen she said that we do have a patient from Scotland, so that answers that question.
Okay, that's great. Thank you.
And that just shows you how effective my team are, because they know
well
my
done.
limitation. And this is why the twin thing is such a good thing. They can, you know, twin sense things.
Yeah. That's good. I'm
like
a twin too.
Yeah.
I'm a twin too, so I kind of get it. Okay, so general question as well, before we get into the specifics. General question. There's obviously quite an infrastructure at St Mark's in terms of the pouch and stoma care. That was clear to see from your presentation. Do other hospitals have similar type of setups, or is it unique to St Mark's? The specific question was about the Royal London Hospital from VPAN. But there are others here as well.
Are we talking pouch specific?
I guess we're talking pouch specific, yeah.
Yeah. So the answer is no, because we are all stoma nurses, as I said. That's our foundation. And when I joined St Mark's as a stoma nurse, when Jo was the pouch nurse, I thought, oh, you know, she just sits there and does her pouch patients, and nobody really knew very much. And I thought that's a relatively okay job. It was only when I became the pouch nurse I realized that a pouch nurse is not a stoma nurse. We do stoma care, but stoma care is a very small part of being a pouch nurse. And I don't want to discredit any of my colleagues, because some nurses that are stoma nurses in different hospitals do have more interaction with pouch patients. But we've got on our databases thousands of families, patients who've had stomas, pouches, and you get a very different experience. We also can manage complications, and I think that's where a lot of stoma nurses run into problems. The pre-op, getting a patient to a pouch as a stoma nurse, we can usually all do. It's more the complication management and the ability to manage this without a doctor. I think that's so for example, Lisa or myself could run a clinic, run a helpline without the need for a doctor. By the time we need a doctor, we would be able to say, we can no longer manage this as a nursing service, this patient needs more input, which I think nurses in other hospitals with pouch patients struggle, and even GPs, because they don't have the experience. And as I said in the beginning, a lot of what we've learned as nurses for pouch patients, it isn't in a course, it's by learning. I mean, I learned how to do a rigid scope with Professor Nichols literally standing over my shoulder, staring at me and asking me what I was seeing in somebody's pouch. I mean, if I think this is bad enough, having Prof Nichols over you, it's quite scary, but you do learn rather quickly. So I think that's why we have a pouch masterclass run for stoma nurses at St. Mark's. And I actually know Vipin, so as he knows, you can always contact us. And a lot of our surgeons, we know at the Royal London, if anybody or any of our stoma colleagues have any pouch problems, they can email or give us a shout. Okay, that's great. That's really great. We've gone past the hour now, but this is such a fantastic opportunity. So with your indulgence, everybody, I'd like to continue, if you're happy to continue, Zarah, until 12 o'clock. Yes. Yeah, that's great. All right. We've actually still almost got everybody all the way through. So everyone's still with us. So we haven't had any drop-offs at all. Well, one's just dropped. Is my dad still there? I couldn't tell you. All right. So let's come on to some real practicalities. And we've had a common theme, some of the questions about pouch emptying. So okay. There's a couple of points here. There's one question. It's not a daft question, Andy J, at all. I also have a W pouch, and it's often been something I dwell on. But are the pouch configurations, is that important in terms of the efficiency of emptying? Presumably the W pouch is more complicated than the J pouch. So before you answer that, there's 2 or 3 other themes here that are emerging. What's the typical number of bowel movements per day that you would expect for a normal, healthy, functioning pouch? That's another question. That was from Devinda. There was another one here as well. We'll come on to talk about catheters in a minute. And if the pouch isn't emptying very well, we'll come on to talk about that in a moment. So bowel movements, and does the pouch absorb too much water? That was a comment that came in, might be related to emptying. Okay, so I've tried to write some of that down. So let's start with, so for the pouch patients that know me really well, I usually have opinions about certain things. And one of the things that I don't get fixed on numbers. Mm-hmm. So there are statistics. So if you look at textbook, the average, amount of times that a patient empties a pouch is probably about 5 to 6 times in the day, and possibly once at night. But for those of you with a pouch, you probably know that doesn't really mean anything. Because as I say to my patients, I've had a lady that's come to clinic that empties her pouch about 15 to 20 times a day. And if you look at that as a clinician, before you meet this patient, you might think they're having a huge amount of difficulties. And really, my patient came in, she was immaculately dressed, she felt well, she looked well, she was happy with everything. She was getting, her priorities were getting to work, getting her children to school, doing a bit of Zumba, and she was fantastic with that frequency because she could manage it. It's about quality of life. So some people get up at night once or twice, some people don't. I think ideally it's if your frequency gives you the sort of satisfaction that you can get on and do what you want, so that your pouch frequency doesn't control your day. That's more important than what's textbook.
Excellent, excellent answer. And can I ask you about leaking as well? Is that the same sort of philosophy for people who experience leaks, or is there specific help that you would recommend?
So leakage, I would like to say, leakage shouldn't really happen with a pouch. Seepage is a different, so it's just the words. A little bit of smearing at night, or a little bit of seepage in the day with quite a lot of exercise, or if you're very tired, or if you probably had a stressful day, is acceptable, as long, again, as it doesn't affect your quality of life, where if you pop a little pad or something in, that's fine. However, leakage, which is becoming a problem, that you become incontinent at night, or leakage that is going through your clothing, that's something that needs investigating. And it's really sad, because I've had so many pouch patients that have come to see me, and we can do something about leakage. You know, people usually have got a narrowing at the anastomosis, the join of the pouch, which means that the more solid stuff is sitting there, and it's the liquid particles that leak. And just dilating that narrowing relieves the problems. Or making sure patients understand how to evacuate properly. A lot of times I say to patients that I haven't met, and when I mean haven't met, people that come to St. Mark's with problems rather than patients that I've known from the beginning. And I teach all my patients, you know, how to evacuate, physically sitting on a chair, showing patients how to evacuate. And the one question I usually ask my patients is, where is your pouch? And I will stand up for this, because a lot of the time, you can see my wonderful Red Lion t-shirt, I say to patients, your pouch is way down here. A lot of the times people think the pouch is in their abdomen, where they've got a stricture, probably from where the stoma was closed. And if you don't know your anatomy, and it's simply because it's not that you don't know, but a lot of patients haven't had a pouch nurse. And it's just making sure that when we're teaching techniques, that your patient knows exactly what you're expecting them to do, or where their pouch is, and what to expect. So I always say to patients, if you are worried that something's getting worse, don't just sit on it and think it's going to go away. You can give us a ring. We can't always fix it, but we can tell you if it's normal or not, or even just reassure you what you're doing is fine.
Okay, really great answer. Thank you very much for that. So let's come on to, we talked about problems emptying, or regularity of bowel movements. One of the issues if people have problem emptying is the opportunity to use a catheter. And we've had a very, very specific question here from Linda regarding continuous use of catheters, and whether continuous use can harm or damage the pouch in any way, and also whether you would recommend either or the Medina or the Quifora, excuse my pronunciation. Thank you. Or either.
So you did well.
Away you go.
So let's just go back to emptying, because you asked me a question about configuration with pouches. So the J pouch is easier to construct for the surgeon. It's simpler, you've got less room for error. The W pouch is simply two J's together, so a bigger pouch, harder to construct, has to be hand sewn, lots of different things. But ideally, whichever shape pouch that you get these days, except for the S pouch, which we really don't do anymore, you should be able, that pouch was made, it's bespoke, it's made for you. So that pouch should evacuate effectively. Over time, we do tend, as the pouch gets a little bit older, like, as I said, everything, the functional problems start to occur, where the pouch was never invented, the small bowel was never invented to work with the pelvic floor, to contract, to fill, to work with the central nervous system and evacuate. So over time, it just doesn't work that well, and there is no good reason for that. However, we can help ourselves as pouch patients to evacuate using a Medina catheter. And I still don't know 100% why a Medina works. It's a small tube with probably about 4 little eyelets on it. And I think it might have something to do with relaxing the sphincter tone, relaxing the abdomen, positioning yourself different on the toilet. But also you aren't concentrating. So you're breaking that absolute concentration and straining and trying to evacuate your pouch. And you're distracting yourself by trying to get a Medina into your pouch. And I think that allows continence to happen because you are slightly distracted. And also it helps to probably evacuate some wind. And I think in a pouch, sometimes if you have quite a lot of wind, that can cause the liquid stool to sometimes not drain as easily. I don't think the Cufora or the Aqua Flush, which is another device that we use, should be just used instead of a Medina. A lot of patients who we suggest using a Medina have an evacuation problem, which means I would not really advise people to put quite a lot of water or any fluid into their pouch if you've got an evacuation difficulty that the water then doesn't come out of your pouch. So I would say, if you have a problem or somebody advises you to use a Medina, you should ideally speak to one of the pouch nurses or ask. And the other thing that we were looking at is actually doing a proper trial. So for people who use Medinas, would you consider trialing an Aqua Flush or a Cufora device to see if it is beneficial? So any volunteers, please let us know. You can't damage yourself because the Medina is quite flexible. So if it hits the side of the pouch, it will bend. But if it does kink a little bit, then it won't drain as well. It's also a rigid plastic, so it's got to be a little bit rigid, and that can kind of catch on any hemorrhoid tissue or skin tags and cause a bit of bleeding, which is why we also do instruct people to use a little bit of warm water in a syringe to sort of purge the outlets as you pull the catheter out. But it would be really interesting to see which device would be better.
Really good, thank you for that. And I know that there'll be a number of people nodding, I can see on the gallery, and certainly Christopher Brown, one of the Red Line Group members, is a great advocate for the Medina catheter. Just to make a general point to everybody on the call, there's an awful lot of information on the Red Line Group website. In particular, previous information days where we've had presentations on a number of topics, including the catheter, including diet, including hydration, including medications. These things are regular topics of interest for people with pouches. So do please log on to the Red Line Group website, which is pouchsupport.org. And if you do some research, have a look at the Information Day resources. You'll see recorded presentations on a lot of topics which are of interest to people with pouches. It's a great information source, I think, for some of the more detailed questions, including a lot of stuff that people are asking questions about today. Let's talk, I'm seeing some questions about the disparity of care in different locations in the UK. We'll come on to those in a minute, but just so you know, I'm not ignoring those, but some very specific questions about care. So issues of inflammatory bowel disease correlating with gallbladder disease, and pouch, how does having a pouch affect liver function? And are there any things to look out for there?
So I'm going to sort of divert that question. simply because the bottom line is it's not the pouch that causes other organs. It's the reason you've had your pouch. So liver conditions are usually associated with ulcerative colitis. And as I said, a lot of, if you cough, people usually think it's something related to your pouch. You've got to realize that when people have a pouch, the pouch is actually the treatment for the disease, your FAP or your ulcerative colitis. But that doesn't mean, especially in the colitic patients, and I suppose the FAP group, that complications from those diseases cannot occur. So for example, inflammation of the liver, desmoid disease in FAP people, cancers and things like that. So I usually like to say is, even if you have a problem, sometimes it's nothing to do with your pouch. You might have gallstones, but you are going to get gallstones without having the pouch, if that makes sense. So it's about investigating things away. And a lot of the times when patients go to see their GPs, and if GPs don't understand enough about the pouch, they probably do link things. And I'm not saying that things aren't linked, but that's where I'm a little bit out of my depth with those sorts of questions.
Yeah. Okay.
Which is again why, at a specialist centre, why we've developed that protocol, so that it's very clear what the nurses do, and actually at the point where you escalate a concern to the relevant team, be it a gastroenterologist who can deal with those sorts of things, or the surgical team.
Excellent. Thank you
so
very
sorry
much.
for being a bit vague on that, but
no, I think it's quite a complicated, these are quite complicated correlations, aren't they? And there's probably lots and lots of literature, specialist literature. Let me ask you about loperamide. Hands up those who take loperamide occasionally. Okay, so this crops up, and we've had a couple of questions about this, but transit slowing drugs like loperamide, what's your recommendations for their use?
Consult your pouch nurse before you start them. No, so loperamide, you're right, it slows the gut down. So the first thing I would say is use it the way it was recommended, and that is on an empty stomach, or half an hour sort of before, 15 minutes, half an hour before. I would ideally say half an hour, but a lot of people, they don't have half an hour, so they usually take it with a meal. It's pointless. The gut and the stomach needs to start slowing things down before you eat. Again, the drug is absorbed in the first bit of the small bowel, so just outside the stomach, and therefore you don't need to have meters and meters of small bowel. So some people think because you've got a pouch, it won't be absorbed. It will. But everybody absorbs drugs differently, depending on, you know, other drugs that you've had, the amount of food that you eat. So it depends on how much you need. So if you usually eat big meals, you might find that you need a bigger dose of loperamide. Some people's lifestyle, their pouch function seems to be a bit more erratic towards the evening. So it's not only the dose you take, it's titrating the dose to your lifestyle. So some of my pouch patients never use loperamide. They manage their diet, they're quite routine, they have a job. Whereas I had another gentleman who used to work nights and days, and it was all a bit, and he used to just have to really work out what he was doing, when he was doing it, how he ate, and titrate his loperamide. So again, the dose of loperamide textbook, we usually say a patient sort of has, you know, 1 or 2 tablets as a dose. So you can have sort of 8 tablets, 16 milligrams per day. But we know pouch patients who can have, you know, sort of double that, 32 odd milligrams a day. But it's about making sure you're using the minimal amount of any drug, because though loperamide is one of the safer drugs to use with the least side effects, for some people you will get side effects like bloating, like cramping, like blockages, or slowing the gut down too much that you end up straining and having other problems.
Yeah, just a quickie, capsules or tablets, either or?
I don't think it matters. You know, you might find that it's GP and cost. We use loperamide capsules. That's what GPs tend to prescribe. And again, since I've been doing my procurement job, it might just have to do with the price of things.
Yeah.
Elixirs or liquids, I know that some people do or who can't take tablets, but the liquids are very expensive for the dose. You might need quite a lot of fluid. And again, this is the idea that we don't want a lot of fluid. So even taking your loperamide tablets, you need to try and not drink a lot of fluid as you're taking the tablets.
Great, really good. Thank you for that. I'm still going to come on to this issue about the north-south divide. We'll come on to that in a moment. I'm conscious of time. There's just one other topic I wanted to raise. We've had one question on this, but I know from moderating the JPouch UK specific Facebook group that it crops up again and again, and that's the issue of fissures. So fissures, presumably, they sound pretty serious to me. What's your advice for people who have fissures and how to avoid them, if there is anything?
So fissures are really sort of little tears in the anal canal. Now, if you've got a rectum and you develop a fissure, it's usually from straining, a tear from constipated hard stool. The problem with a pouch patient is if you develop a fissure, a lot of patients describe it like passing glass. So it's a tiny little cut in the anal canal, but because you're passing stool with enzymes and stomach acid probably still in that output, it is extremely painful. Yeah. We usually treat them successfully with diltiazem or GTN ointment, which, and I say ointment because sometimes the cream just, you know, it depends. Some people benefit with the cream, the ointment's a bit oilier. But a lot of the time, it's not only using the diltiazem, it's actually the way you apply it. And I usually say to patients, you need to kind of get the cream in your anal canal and actually wipe it around the anal canal in a circular motion so it completely coats that area. That brings the blood flow into that area to heal. Because unfortunately, unlike somebody with a rectum and a fissure who go to the toilet once a day, somebody with a pouch is potentially going to the toilet quite a lot, and that is what causes the problems. You've got to be careful with diltiazem because even though it's being used anally, it can interfere with blood pressure, and some people feel a little bit dizzy and have other problems with it. So it's still a drug you have to be careful with. But again, if you've got any problems, please let one of us or somebody know. Some people might get a little tear or a fissure when using a Medina. Forgot to mention that, but a lot of the times it's the other way around. The Medina doesn't cause the fissure, you get the fissure and then the Medina makes it either worse or incredibly painful that you can't use the Medina.
Yeah, indeed.
Which is another good reason just sprung to my head why we should be trialing the Q4 or Aquaflush.
Okay, Aquaflush was mentioned as well in the questions and comments. All right, we've got a few minutes left. I just wanted to come on to the topic, and my apologies if we haven't got round to your specific questions if you ask them about clinical aspects, but the general topic about care nationally and why there'll be a lot of people here and certainly on other chat groups who live remotely to London and also Oxford, where I know there's a good infrastructure there around John Radcliffe Hospital for people with pouches. But outside of those centres, it's patchy. And particularly in remoter regions, there's much less care specifically for pouchees. The 2017 Association of Coloproctologists report talked about centralising or recommended centralising specialist surgery like pouch surgery in highly efficient and effective centres. But you've still got this community remotely located who perhaps feel isolated or remote from this sort of specialist care. Do you want to comment about whether that's appropriate, whether it's continuing? You did mention, I think, the drop in pouch operations might be related. One of the suggestions was to other centres doing pouch surgery other than St Mark's. And that kind of flies in the face of that Association of Coloproctologists report.
Yeah.
So
Yeah.
nationally, are you still seeing lots of local centres doing 1 or 2 operations in a 5-year period? That was the observation they made. And how do we as a national charity and other organisations reach out to people who perhaps feel remote from London and St Mark's and Oxford to get this sort of specialist care that they may be seeking?
Okay, so this is a sort of dangerous line to tread. So I'm going to use one of Professor Clark's quotes. The pouch operation is like having a classic car. Now, the other alternative is a Ford Fiesta. And I'm not going to say this exactly, but the pouch patients, you are unique. Now, you can't take your classic car to any old garage and have it serviced, have it looked at and get a spare part fitted, because you need an expert team. And this goes back to the reason people have pouches. And as I said, I have been a pouch nurse for long enough to see that even at Oxford, we used to have a lot of support at Oxford, and even there, with Professor Mortensen retiring and the Professor Nichols retiring, you lose that expertise. And I have to agree with my surgical colleagues that you can't be good not just doing the operation, but if you look at statistics and you only do 2 operations and they go relatively well, you could have 100% success rate. Whereas somewhere like St Mark's, we do have complications because we take a lot of patients that are very complex to start with. But if you want to have a very specific operation, you should, for your best interest, go to a specialist centre. And if you think about specialist centres for lung disease or the Royal Marsden for cancers, there are specialist centres for this reason. And one of the criticisms I had as a pouch nurse, and the difficulty I have training pouch nurses today, is that we don't have the resources now, because when I was training, as I said, I had Prof Nichols to hold my hand. I had 30 odd patients a week in clinic that just were healthy, well patients that I could just scope easily, that weren't in pain, that were willing to have a scope. Now we've sent all of those patients away because we've realized they don't need to be coming to clinic just to have a scope. So the routine patients, it's very difficult to train my team now because I have to physically be there to explain all the complexities. So I really think when you're thinking about having a pouch, you need to think about where you're going to have it done, because it's not just the surgeon you need an entire team. And I've said this before, but one of my dreams was to get a bus and drive around the country and pick up all the pouch patients. And somebody said, well, you know, you can actually have a big enough bus and nurse them in your bus. So those are still ideas I'm toying with, but I think patients need to have access, and that's what I would like to make St Mark's be, a bit more technology equipped, virtual clinics, links, our stoma nurses and pouch nurses working a bit more together so that the resource, the workforce is there. Training other nurses. As I said, we ran a course quite successfully for about 5 years, and patients being aware that if they do get referred into St Mark's, I need to take this information back to my surgeons about if we are doing these specialist operations, we do need to have the resources. We can't just do a pouch operation and then expect people to get on with it. They do need support, lifelong support.
Absolutely brilliant. Thank you so much. I'm going to draw this to a close now, not because I want to, not because, well, I think it's just good could
Well, I
proceed.
do have patience to see, David.
Yeah, I'm sure you do. So we can't go on forever. So my apologies if I didn't get around to ask your specific question, but we've
But
kept
please
Zarah.
email them if anybody thinks that they've got a personal question. Can you get them to us?
Of course, and indeed there'll be a recording of this event on the Redline Group website, and in amongst your presentation you had a slide which very helpfully gave contact details. So if people didn't have the chance to write it down, then please have a look at the recording when it's posted and you'll see the details. Listen, thank you so much. We've got as many people on the event as we had at the start, so thank you so much. That's a testament to you.
Thank you for staying.
Some people have worked out how to do claps electronically. That's very cute, but I prefer that. I quite like that. But thank you very much indeed on behalf of us all for your time and an extremely interesting presentation and all the answers to the questions as well. So thank you so much from everybody. Just to say, there'll be a recording of the event on the Redline Group website in due course. Next week, we have Professor John Nichols and last of the series of conventional presentations. Please do register for that if you'd like to hear Professor John Nichols speaking, have the chance to ask him some questions. And lastly, after the John Nichols talk, we're going to have an AGM. The AGM is something which is necessary for us to do every year. We normally do it as part of the information day. Unfortunately, because of COVID, we had to cancel the information day for this year. We still have an obligation to do an AGM. So we'll be putting something on the website about that. I know it's short notice, but if you are on the John Nichols webinar next week and you'd like to stay on for a few moments, we'll go through the formalities of the AGM. If you're a member, you'll be entitled to stay on. That would be great if you can do that. Make sure we get Corate. So there'll be some more information emailed out to you about that. And then moving forward after that, in the coming weeks, we're going to trial using this Zoom technology for some a sort of coffee morning type event for pouchies, rather like the breakout events we've had in the past at information days, which have proved extremely popular. So coming back to this point that Zarah was making about reaching out to communities of pouchies in more remote parts of the country, this Zoom facility really offers us that opportunity. So we thought we would trial a coffee morning opportunity, a couple of stories from people with pouches on their journeys, and then an open comment, question and answer session. I noticed Steve and Chris have already got their coffees ready. It'd be really nice if you could look out for that and join us for that, and we'll see if that's a successful opportunity for people in the future. Without further ado, thank you so much again to you all for your attention, and thank you again to Zarah for your time today.
Thank
all
you
the best.
for having
Keep safe
me.
out there.
Bye.
Keep safe. All the best. Bye-bye.